Again, it's now my pleasure to introduce Ben Solomon. We all know who Ben is, a real world leader and a fantastic advertisement for research in Australia. Ben.
Thanks so much for the kind introduction, Ken. So I'll be talking about KRAS-mutant non-small cell lung cancer, and I'd like to start with a clinical case. So this is a 69-year-old male heavy smoker who presented with cough and weight loss. His CT scan shows an area of mass-like consolidation in his lung and metastatic disease to mediastinal lymph nodes and a right adrenal met. A biopsy demonstrates a lung adenocarcinoma, which is PD-L1 0%, and has a KRAS G12C mutation detected on NGS. So how would you treat this patient? Would you start with chemotherapy and immunotherapy and then a KRAS G12C inhibitor in the second line? Upfront KRAS G12C inhibitor, chemo plus G12C inhibitor, G12C inhibitor plus Pembro, or the kitchen sink? I'd contend at the moment we don't actually know, but I think there's data that's coming that's going to really inform our decision. So let's sort of go through that a bit. So KRAS mutations are found in about 25 to 30% of patients in Western populations like Australia, lower frequency in Asian populations. And for most patients with KRAS mutations, particularly G12C mutations, these patients tend to be current or former smokers. Looking across, Sanjay had a very nice comment about there being no EGFR mutation positive patients and there's heterogeneity, and the same applies for KRAS. There are multiple different KRAS mutations, and we do need to start thinking about which specific mutations we're talking about. In the context of lung cancer, and it is different in lung compared to colon or to pancreas, in the context of lung cancer, the most common mutation tends to be KRAS G12C, but there are other non-G12C mutations like KRAS G12D and G12V, as well as a variety of other mutations. And again, it's important for us to look at the molecular pathology report beyond just the first four letters, KRAS, and look at what specific type of mutation. Now, the different strategies to block KRAS. We can use mutation-specific inhibitors, mutation-selective inhibitors. These target particular mutations like G12C or G12D or G12D. We can use pan-RAS inhibitors, and there are a range of these being developed, which inhibit a spectrum of mutations in KRAS, sometimes not the complete spectrum. Some mutations, in particular G12R, can be very difficult for these drugs to inhibit. And pan-RAS inhibitors, which inhibit not just KRAS, but NRAS and HRAS. So not so long ago, someone would put up a slide and say KRAS is undruggable, but far from it. This is probably an incomplete sort of diagram of the number of KRAS inhibitors in clinical development. And probably the biggest bunch is the blue block, which is the G12C inhibitors. But following shortly after are the G12D inhibitors, which are at the yellow block, the pan-RAS inhibitors. We're now seeing G12V inhibitors. So things really are changing. I think Mel, as chair, will be pleased to know that I'll be focusing on a small subset of these, the G12C inhibitors in non-small cell lung cancer. So the first-in-class was sotorasib. It targets this KRAS G12C mutation. And there was very clever medicinal chemistry that identified a pocket on KRAS, which drugs can covalently bind and inhibit. And I think these data were remarkable when they were first described. These are the data with sotorasib in patients with G12C mutation-positive non-small cell lung cancer, an objective response rate of 37%, median progression-free survival of 6.8 months, but only remarkable because this was KRAS, and this is very different to what we've learned to expect with targeting other oncogenes. We see similar results with another G12C inhibitor called adagrasib, and we can probably consider sotorasib and adagrasib as the first generation of G12C inhibitors. We see a response rate of around 40 months, median progression-free survival of 6.5 months. But even within this subset of G12C mutation, we recognize that there's molecular heterogeneity, and there are co-mutations that occur along with the KRAS mutation that might be important in influencing degree of response and durability. And I think P53, STK11, and KEAP1 are the common co-mutations we see, and some of these, in particular KEAP1, may be potentially important modifiers of response and prognosis in the context of treatment with G12C inhibitors, and I think we're going to see some data indicating the importance of KEAP1 in particular emerging over the next few months. So the first generation inhibitors have been tested in phase 3 trials against the standard of care docetaxel, which we heard was a tough bar to overcome. Sotorasib in the CodeBreak 200 study. And the study was positive for its primary endpoint of progression-free survival. It did beat docetaxel with a hazard ratio of 0.66. But I think people were a little bit disappointed with this result because there was only about just over a month improvement in progression-free survival. And in overall survival, there wasn't a difference. We've seen very similar results with adagrasib. We've only got the progression-free survival reported, but really very similar magnitude of benefit compared to sotorasib, with a hazard ratio of around 0.68. Survival results are pending. But we also have seen significant toxicity with these agents, in particular gastrointestinal toxicity and also hepatotoxicity. And Sanjay and his team came up with a very early astute observation that some of the toxicity, some of the hepatotoxicity did seem to have an immune component and did respond to treatment with steroids. And that has important implications for some of the combinations we're starting to see in terms of combinations with PD-1 inhibitors. So what about the newer generation of G12C inhibitors? There are a bunch of them, a large number in fact, which are in development, and they all seem to have advantages over sotorasib and adagrasib in terms of potency against KRAS, which actually has translated into differences in efficacy. So it's not, prior to the advent of these drugs, it wasn't clear whether KRAS was just, there was something different about dependence of tumors on KRAS, or whether it was related to the drug, but potency does matter, and we are seeing, as I'll show you, different results with these more potent inhibitors. So divarasib is one of these inhibitors. Preclinically, it's more potent against KRAS G12C than sotorasib or adagrasib. It's got different kinetics of binding. I should add, like sotorasib and adagrasib, it is what we call an off-state inhibitor. KRAS is a GTPase, and it's active in its on or GTP-bound state. These drugs bind to KRAS in its off or GDP-bound state and prevent it from moving into the active state. So similar mechanism of action, but more potent and binding with different kinetics. And we know that it seems to have different efficacy from this phase 1/2 trial. The response rate here is closer to 60%, with a median progression-free survival of just over 13 months. So again, closer to what we've learned to expect with ALK and EGFR, conventional mutation EGFR targeting therapies like osimertinib. Now, importantly, divarasib has been compared not with docetaxel, but with the first generation G12C inhibitors, adagrasib and sotorasib in this study, Crescendo-1. So these patients who had received prior chemotherapy were randomized to either divarasib or adagrasib. There were stratification factors, including the presence or absence of KEAP1 mutations, CNS metastases, and choice of adagrasib or sotorasib. And the primary endpoint of the study was progression-free survival and a number of secondary endpoints, including overall survival. And we learned just over 2 weeks ago that this study is positive. And importantly, it's positive not just for progression-free survival, but also for overall survival. And we'll be hopefully hearing the results of this study potentially at ESMO this year. There are, I won't go through all the newer generation G12C inhibitors, but this drug, adagrasib or D3S001 is another example. Again, response rate of about 60% and a median progression-free survival of 9.4 months in the second-line setting. What about novel G12C inhibitors? So these drugs that I've described previously are all these off-state inhibitors. But there are drugs that are developed that can inhibit KRAS in its on state. One of these drugs is one of these so-called RAS-ON inhibitors, is this G12C selective inhibitor called adagrasib. Now, it works in a very similar way. Those of you who were at ASCO or understand on Instagram saw the standing ovation at the ASCO plenary of daraxonrasib, which is the pan-RAS inhibitor, which works essentially in an identical way to this drug. So this drug binds an abundant cytoplasmic protein called cyclophilin, and the cyclophilin in complex with adagrasib then binds to RAS in its on state. And this tricomplex is not able to bind RAS effector proteins, so it's essentially shutting down signaling from the RAS-ON complex. And this drug looks pretty good in early data. The confirmed objective response rate is around 56%, median progression-free survival about 10 months in KRAS G12C inhibitor-treated patients. There's another drug called BBO-8520, which is a small molecule covalent inhibitor which is able to bind and inhibit both RAS on and off, so a bit different to the tricomplex inhibitor, and again more potent than sotorasib, adagrasib, and divarasib. We don't have much data from this drug yet, but again it seems to have similar degrees of efficacy. What about first-line therapy? I guess a lot of our thinking about first-line strategies were based on the maybe less than completely impressive second-line data, thinking that single agent wouldn't really cut enough mustard to beat KEYNOTE-189 as a more effective first-line therapy. So there's been a lot of effort into developing combinations of these G12C inhibitors with chemotherapy and or immunotherapy. So one of the first attempts is to combine sotorasib with chemotherapy. Now, I should say there have been attempts to combine sotorasib with immunotherapy, but the toxicity has been prohibitive. That doesn't apply to some of the other agents, but certainly applies to sotorasib. And this is a study from Japan, the SCARLET study, which showed a very impressive objective response rate to the combination, but a little bit of an underwhelming progression-free survival. There was another study, the Sherlock study, which is a TOGA-led study led by Chi Li, who's in the audience, and you'll hear more about this study tomorrow, but this study showed a really quite impressive objective response rate of 64%, and I'll invite you to attend tomorrow's presentation to hear more about this combination. There's a lot of interest in combining, and we'll hear more about this from Kate's talk, interest in combining G12C inhibitors with immunotherapy, and part of the rationale for this is that G12C inhibitors or KRAS inhibitors can modify the tumor microenvironment, doing things like increasing MHC expression, altering the composition of the microenvironment, potentially making tumors more immunosensitive, so hence a rationale for combination with immunotherapy. And given this, there have been attempts to combine with single-agent pembrolizumab, but also, interestingly and impressively, with chemo-pembrolizumab. So these are data from a G12C inhibitor called olomorasib in combination with pembrolizumab, which shows a response rate of 74%, in combination with the same compound in combination with chemoimmunotherapy, with response rates of 61%. Of course, these combinations are associated with increased toxicity, including things like hepatotoxicity and the gastrointestinal toxicity, which I mentioned. Similarly, with divarasib, there's encouraging data in combination with pembrolizumab, with response rates of around response rates of 72% in PD-L1 positive patients, and interestingly similar response rates in PD-L1 negative patients. But the idea of the need for combinations is being challenged a little bit by some of the emerging data with the newer agents. This is the drug I mentioned earlier, D3S001 elisrasib, as a monotherapy in combination with pembrolizumab. And now in the first-line setting, in patients who haven't received prior chemotherapy, you see response rates pushing up above 70%, 78% with the monotherapy. Very similar results with the pembrolizumab. So it's really hard to know what the best partner is needed and whether every patient will need to have the same combination. What we don't have mature data on is the durability of these responses, and it may be that the addition of the combination partner doesn't change the response rate much, but might improve the durability of the response, and that's what we'll find out. And we'll get the answer to these questions from these ongoing first-line phase 3 studies, which will report, I think the Sunray study has completed accrual, so results are not far away. So what about our patient, a PD-L1 negative patient with a KRAS G12C mutation? This patient enrolled on a trial, the Crescendo 170 trial, which was a combination of divarasib and pembrolizumab, and had a very rapid symptomatic response and a rapid radiological response, as you can see in this area of mass-like consolidation, as well as in his adrenal mass. And I think how we treat these patients will be answered by the trials that we'll hear reported. So we've moved from KRAS being undruggable to having a plethora of agents available. We've seen the data from the first-line agents, but these are already being usurped by the newer G12C inhibitors in development, and we've got a range of more other inhibitors that we're going to see data from. We've got combinations, but we do have challenges related to toxicity and managing resistance. Thanks very much.
Wonderful overview. We've time for a couple of questions. Any questions from the floor? I just have one quick one. Do you think we might be getting close to a situation where we don't have to use chemotherapy and we can just use these combinations. What's your feeling on that?
Yeah, I think that's likely. I think it's hard. It's hard to think that we wouldn't be using immunotherapy. I think the chemotherapy is the easier one to drop out. But I think we might move to a situation where we start to sort of look at things like KEAP1 and work out who needs to be intensive, an even more intensive treatment, and chemotherapy might be a component of that intensification, or ADCs, as we heard earlier this morning.
Okay, if we have no further questions, we move on. Thanks a million, Brennan. Fantastic presentation again.